Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about mucoepidermoid carcinoma. We'll talk about some MCQ related questions related to this. We'll talk about its histogenesis. We'll talk about the histology, what do you see microscopically, clinical features, investigations, and how we'll treat the disease. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, mucoepidermoid carcinoma is actually the most common malignant salivary gland tumor. Do you know which is the most common in general salivary gland tumor? That is pleomorphic adenoma, and that is also the most common benign salivary gland tumor. But if you look at the most common malignant salivary gland tumor, that is mucoepidermoid carcinoma, and it is also the same case in case of children as well. So, what is this carcinoma? This is a malignant epithelial tumor of the salivary glands which is composed of variable proportions of three types of cells. I will talk more about these cells under histology. So, the main pattern over here is, so if you look at the name muco, meaning mucus cells, so it has mucus cells, then epidermoid, meaning squamous type of cells. So we have epidermoid or squamoid cells as well, and we have some intermediate cells. And all of these three cells together, they form a cystic and solid architectural patterns. And that is what mucoepidermoid carcinoma is. So this comprises about 5% of all salivary gland tumors. And the age group is actually a wide range of age group. So it is seen right from third decade to eighth decade, but however, the peak is seen around the time of fifth decade. And just like all other salivary gland tumors, this is also more common in females. Can you tell me which is the one salivary gland tumor which is more common in males? That is Warthin's tumor. This is a very important MCQ that you should remember. Most salivary gland tumors have a female preponderance except for Warthin's tumor. Now let's talk about how does it originate? What is the histogenesis of this? As I've spoken about in my previous class in malignant salivary gland tumors, when I was discussing histogenesis, I talked about the reserve cell theory or the stem cell theory. So, most likely, the mucoepidermoid carcinoma, it arises from these reserve cells, which are basically pluripotent cells of the ductal system. And these differentiate into these different types of cells that we are finding in this carcinoma, which is the mucus cells, the epidermoid or the squamoid cells, and the intermediate cells. Also, other than this, prior radiation exposure is also a risk factor associated with development of mucoepidermoid carcinoma. Next, let's talk about the histology. So, when you look at it macroscopically or gross examination, what do we see? So, we see a well circumscribed tumor, but it does not have well defined capsule. That is important to remember. So, because of the capsule not being present, it often infiltrates at the margins. And when you look at the cut section of this tumor, we see that it is pale and gray white, and it frequently contains multiple small mucin containing cysts. So that is what is seen on gross examination. Now let's look at the microscopy of this. So as I mentioned before, this is primarily composed of three different types of cells. What are these cells? First is the mucus secreting cells. So now the mucus secreting cells are basically this large ovoid cells. So they are basically large cells like this, which has abundant foamy cytoplasm and it is filled with mucin. And because of this, the nucleus gets pushed peripherally. So that is how a mucus secreting cell look like, and they are full of mucin within it. Next is epidermoid cells. So epidermoid cells, these cells are polygonal cells and they have squamoid features like intercellular bridges. And even sometimes you can even see keratinization in these cells. And the third type of cells is, if you look at the images over here, these are the mucocytes and then these are epidermoid cells. You can see that they have intercellular bridges in between them. And the third group of cells is intermediate cells, also known as basaloid cells. These are this very ovoid looking cells with very dark staining nuclei and scanty eosinophilic cytoplasm. So these three are the main microscopical features that you would be seeing in mucoepidermoid carcinoma. Now, depending on the histopathological findings, we also grade this tumor into low grade, intermediate grade, and high grade. Now, how does this differentiation occur? So, in low grade tumors, mostly we see more of mucus cells than epidermoid cells. We'll see a lot of cysts, and because we have more mucus cells, this will contain mucin, and they have very minimal cellular atapia because atapia is a feature of a high grade malignancy. Next, in intermediate grade, we'll see that number of mucous cells and the epidermoid cells are more or less equal. There are fewer and smaller cysts, and there is increasing pleomorphism and mitotic figures compared to low grade. And thirdly is high grade. So high grade tumors are where we have more epidermoid cells than mucus cells. And these cells are more arranged in the form of solid nests and cords with very less cystic spaces. So we can see in low grade we had more cystic spaces and mucin, but in high grade we have less of that. And here the nuclear pleomorphism increases and there's also increased mitotic activity. So this is how we grade these tumors into low, intermediate, and high grade based on histopathological findings. Next, let's talk about where does this tumor arise usually? What are the more common sites? So the most common site overall is parotid. But if we had to ask what is the most common intraoral site, in that case, it would be the palate. But so parotid is the gland where most of the times it is involving, like in about 70 to 80%. And in other cases, the minor salivary glands are involved. Other than palate, it can involve the buccal mucosa, the tongue, retromolar area. Now let's look at the clinical features. Now we can divide clinical features into two parts. Is it a low grade malignancy or a high grade malignancy? So in case it is a low grade tumor, in that case, we see a slowly enlarging painless mass. So what does this depict? This is actually this is a complaint that we see more in case of pleomorphic adenoma. So it is basically simulating that of pleomorphic adenoma. You won't be able to differentiate between them just based on clinical examination. These tumors are usually less than 5 centimeter in diameter. And as I've mentioned before, they contain a lot of cysts that can be filled with viscid mucoid material. They are not completely encapsulated, and intraoral tumors resemble a mucocele because of its cystic appearance. If you look at the image over here, we can see a submucosal swelling in the hard palate, and we can see that how this looks very close to a mucocele because a low grade mucoepidermoid carcinoma of the palate is actually is very cystic in nature. So it is looking very close to that of mucocele. So these are the features of a low grade tumor. If the tumor was high grade, then in that case, we'll see that there is increased growth. So there will be rapid growth happening. The patient may complain of pain, facial paralysis, and if minor salivary glands are involved, in that case, it can lead to other features like trismus, drainage from the ear, dysphagia, numbness of adjacent areas, even ulceration can happen. It can infiltrate into the surrounding area, and also it can have metastasis to the regional lymph nodes and other distant sites like lung, bone, brain, etc. So that is all the features of high grade tumor of mucoepidermoid carcinoma. Now that we have seen all the clinical features, how will we investigate this case? So first of all, as usual, we'll be performing an ultrasound, which is our first line imaging over here. Next, we'll be performing a contrast enhanced CT scan or MRI. MRI is preferred over here. It is a gold standard for soft tissue delineation. Why will we perform a CT scan or MRI? It will help with deciding the extent of the tumor locally, if there is any deep lobe of involvement of the parotid gland, if there is any other invasion like bone erosion or skull base invasion, or if there is perineural spread. Perineural spread will be more easily delineated in an MRI rather than CT scan. And thirdly, we'll do an FNAC. And last of all, we can do a chest X-ray to look for distant metastasis. So that's how we'll investigate this case. Coming to treatment, our only mode of treatment, or rather a main mode of treatment over here is surgery. Let's first talk about how we'll deal with the primary, and then I'll talk about how we'll deal with the neck node if present. So in case of primary, let's talk according to site. So if it involves the parotid, first we have to see if the tumor is of low grade or it is involving just the superficial lobe. In that case, we can just perform a superficial parotidectomy and preserve the facial nerve. But if the tumor is involving the deep lobe, or it is high grade, or the tumor is very large, that is more than 4 to 5 centimeter, in that case, we'll perform a total conservative parotidectomy. We'll try to preserve the facial nerve if it is not involved. But in case the facial nerve does get involved, we will remove the facial nerve and perform a grafting or reconstruction of the facial nerve. So that is treatment of the parotid tumor. If it involves the submandibular or the sublingual gland, we'll perform a complete excision of the gland with margins. And if it involves the minor salivary glands, we'll do a wide local excision with adequate soft tissue and periosteal or bony margins, and then perform adequate reconstruction. So that's about treating the primary tumor. Now let's look at the neck treatment. So in case we find clinically positive neck nodes, in that case, without any doubt, we'll directly go for radical neck dissection. But in some cases where we do not have a clinical neck nodes, when do we consider elective neck treatment? Now, elective neck treatment can either be neck dissection or radiotherapy. The indications for elective neck treatment in the absence of clinical neck node positive would be having high grade tumors, T3 or T4 tumors, and clinical high risk features, which I have just discussed a little while back. So that's about the neck treatment. Now let's talk about post-operative adjuvant radiotherapy. What are the indications of that? Again, high-grade histology is the number one indication. If after surgery there is positive or closed margins, if there is perineural invasion, extraglandular extension, multiple nodes or extracapsular spread, and in cases of advanced T staging. These are all the cases where we'll give post-operative adjuvant radiotherapy to the patient as well for a better outcome and better local control rates. Last option is chemotherapy, but chemotherapy has very, very limited roles. Maybe it has a little bit of a palliative role in the treatment of these tumors. That's all about the treatment. Next, lastly, let's talk about the prognosis. So if this is a low grade tumor, in that case, they have excellent prognosis after adequate surgery has been performed. But if it is an intermediate or high grade tumor, in that case, they do have a higher risk of local recurrence or higher risk of even nodal metastasis and distant metastasis. So that's all about mucoepidermoid carcinoma. If you have any further questions on this, please note them down in the comment section and I'll get back to you.